Okay, so anaphylactic reactions or allergic reactions, same sort of thing. You get into anaphylaxis, which is saying that you're having an allergic reaction of some sort. The worst, of course, is anaphylactic shock, when the patient goes into shock. You get different varieties of allergic reactions. Have you guys ever had an allergic reaction before? Yeah, I mean most everybody who's experienced life has had some form of allergic reaction. I mean, from soap or bugs or grass. Most everybody's allergic to grass. They just don't realize it. You roll around the grass, you're going to itch, right? So anyhow, so you get these different reactions here. This may look bad, but if it's a localized reaction, not so bad. This may look really bad, and it is getting towards the worst here. But this guy just looks like he didn't do his homework, and Dad got mad at him. But here, this is bad because the tongue is swollen up, and it blocks the airway. It can block the airway, and then once it swells and swells, that's the most serious. Is when the airway starts to swell and shut. Now, you've heard of them saying, "Oh, their airway's going to close up." It does, but it swells. The airway swelling. We have to look first at the medication that we're going to give for these allergic reactions. One medication that's very common is Benadryl or diphenhydramine. All right, anything with this ending on it here is the same class of drug. So the class of drug for Benadryl is an antihistamine. Okay, it doesn't necessarily stop the release of histamines. We know from asthma sort of what histamines do. They cause bronchoconstriction and a few other things, but mainly what we're concerned about is bronchoconstriction. So that's the antihistamine. It doesn't necessarily stop the release of histamines. What it does is it blocks the histamine. I don't know if you can see the little picture there, but let me draw. You have this mast cell, which is full of histamines, okay? Now, we keep it a little simpler, okay? I mean, it's full of a bunch of stuff, and a bunch of stuff gets released, okay? But for today, we're just going to concentrate on the histamines, all right? Because there's the basal pills and all these other things that get released as well. But on top of here, it has a little receptor site. We should be familiar with that receptor site. Okay, and the histamine will float along here, and once this histamine joins up with this receptor site, it's going to open the cell up to release this mast cell, to release not histamine, my bad. It's Monday, give me a break. All right, so you have this antigen, these antigens floating out here, and once this antigen sort of hits this receptor, it's going to open that cell up, okay, and then the cell is going to release histamine. All right, so what Benadryl does, its action is it blocks the histamine receptor site, so it puts a little chemical door right there. So as these antigens float around, it can't combine up with this receptor to open this cell to release histamines. Once this takes place, then this cell is going to release histamines, okay, until it's blocked or the allergic reaction has stopped. And essentially, histamines is one of the causes of the problems. All right. We use the bee sting because it's real common. All right. So, yeah, I should have used this picture. Okay. I looked up here and I was like, oh, I didn't see this one. But these IgEs, this immunoglobulin, whatever that thing stands for, okay, essentially hooks up in this receptor, then it releases the histamine, and all the bad things happen when it releases histamines, okay? These antibodies come up here and do that. So the antigen, or the the thing that's causing the allergic reaction is like what you're allergic to, peanuts or bee stings or whatever, right? Whatever the case may be, that's what's causing the allergic reaction here. What we want to do is block this histamine from flowing out, for one, so Benadryl is really good for that as well. It does, if you take oral Benadryl, remember it takes about 20 minutes or so for it to take effect. So and it's an antihistamine. There's a bunch of antihistamines. I take one every morning for Allegra for allergic reactions, allergy medicines, right? And so to prevent, hopefully, these allergies from getting floating around here. So and then Flonase, right? The nasal spray to prevent allergic reactions or allergies. But we're talking about something a little bit more serious here, like this patient would be allergic to this bee sting, and then it would be the antigen. Right? So we would administer Benadryl to that patient, okay? And Benadryl can be given PO, right, by mouth, IV, IM, intramuscular. So we'll explore those different ways that would give Benadryl. In the severe cases, right, they would give them epinephrine, and it comes in a auto-injector, which is the most common part of it, okay? Now, does anybody carry an auto-injector? Are you allergic to anything that you have to carry an auto-injector? Trust me, these guys with allergic to bees and peanuts and everything, they have these. They carry these around. Especially peanuts. I heard of students the schools are getting where you can't eat a peanut butter sandwich in the cafeteria now because of peanut oil and everything. They have these severe allergic reactions to peanuts. So they carry these around with them because that patient only has a few minutes from the onset of this reaction sometimes, depending on how violent the reaction is, to death. So that airway swelling up. Okay. We're not necessarily talking, the most violent reaction is not necessarily the tongue swelling, but the airway, the pharynx swelling, and it can swell shut, and then there's nowhere for the air to go in, right? So if that happens, emergent-wise, you would hope somebody would come along and do a surgical airway. They would have to cut an airway in this person's throat, which is frightening. Okay. So, for the person doing the cutting, not for I guess the person laying there dying is frightened too, but it is rather frightening for all people, doctors included. I've dealt with some doctors who are doing surgical airways, and they're like, "Come on, doc, you paid the big bucks, cut, time to cut, don't wait too long." It has happened before, but the Epipen, you may have remembered on the news some time ago where the manufacturers jack the price up to like $300 a piece, it's life-saving. If you have an allergic reaction to like bees or whatever, peanuts or whatever, those big allergic reactions, then an Epipen, right? In an ampule, which we're going to learn that just another day, how medicine is packed. In an ampule, it's like 33 cents for 1 milligram. 1 milligram of epinephrine is 33 cents. Last time I checked the price, okay? And that's 1 milligram, so that's actually 3 doses because the dose of epinephrine coming out of here is 0.3 milligrams, okay? So 3 doses for 33 cents or $300 for the auto-injector. When that happened, some other people came up and started manufacturing different ways to inject it. But that's what we'll learn. We'll learn after the break to give sub-Q injections, and that's the most common way. This is how this is given as well. Okay, but epinephrine, the medication, what it does, and we've talked about this in the past, I believe. It's a beta-1. So it's going to affect the heart rate. 1 beta-1, 1 heart, right? And a beta-2 drug. These are properties of the medication. So a beta-1 property will increase the heart rate. And a beta 2, 2 lungs, that's how I remember it. 1 heart, 2 lungs. So a beta 2 is going to have pulmonary effects, which is going to cause bronchodilation. Okay, that's what we want, bronchodilation. Okay, and then the medicine also has alpha effects to it, or alpha properties, which causes vasoconstriction. So when the patient takes the Epipen or a shot of epinephrine, like here for the allergic reaction, this is what's going to happen. So one of the side effects is an increased heart rate. The outcome that we want is the bronchodilation, because the histamines will cause what? Constriction, right. The histamine will cause bronchoconstriction the same way it does in asthma. With the so we want to dilate the bronchioles, and then if the patient sort of starts going really south into an anaphylactic shock, it'll cause vasoconstriction whether the patient's going in anaphylactic shock or not. But we use this in the short term for someone going into anaphylactic shock, the vasoconstriction. No, not even a sympathy laugh. Finger there. Okay, never mind. The vasoconstriction. So, what if we have vasoconstriction? What's going to happen? What is the expected outcome? Increase in blood pressure, right. We constrict that vessel, we don't change the volume, we restrict the vessel, the container, the pressure is going to increase, right? So if the patient's in anaphylactic shock, which is one sign of that is hypotension, right? So we want to constrict their vessels with this epinephrine. The class of drug for epinephrine is a sympathomimetic. Sympathomimetic. Okay? Say that quick 5 times. You start to sound like you're having a stroke. Sympathomimetic. Anyway, sympathetic nervous system. I mean, this is what the body releases in the fight or flight, right? If the adrenal cortexes release epinephrine, it's going to do the same thing whether you inject it or the body releases it. Okay? So this suffix here means to mimic. So epinephrine is going to mimic the sympathetic nervous system. So you don't really have to memorize anything else. You already know what it is by knowing the class, right? Class is a sympathomimetic, and it's going to mimic the sympathetic nervous system. Now, the thing with it is you can also remember what the drug does just by knowing what properties it has, these beta properties, okay, and these alpha properties. So, by knowing this, you would know some of the contraindications of it, right? So what would be a contraindication of epinephrine?
High blood pressure.
Well, let's put a different term, a relative contraindication. A contraindication is absolute. You can't give the medication. Okay? A relative contraindication means that you have to sort of be careful giving the medication. Because this is a life-saving medication. And we reproduce. Everybody produces epinephrine. Okay? It's a reoccurring hormone in the body. Everybody produces it. So can you be allergic to it? Not really. You can't be allergic to it. You can be sort of sensitive to it. So, high blood pressure. Right? What else would be a sort of a relative contraindication of epinephrine?
It says during labor, hemorrhagic or cardiogenic shock.
Nah, yeah. I don't know. Yeah, dysrhythmias. Heart rate, right? Because it's going to increase the heart rate. Now, if you're a healthy person, you can take a little epinephrine, and it'd be just sort of like albuterol. Albuterol and epinephrine are like cousins. They're sort of in the same family. They're not the same, but they're sort of in the same family because they cause a lot of the same results. Like albuterol will cause an increase in heart rate, right? It won't cause basal constriction, but it causes bronchodilation. So there's a little bit of the same. So you have to sort of watch that heart rate. But if someone's dying and their heart rate is up there, then, give them the epi. Don't let them die, right? Now, one thing that you have to be cautious of in giving epinephrine is the fact that people are old. So if you give it to grandpa, you could induce a heart attack, okay? So you do have to be cautious in that. But again, you have to weigh the options when you start looking at this, okay? Do you let them die, or do you, maybe you decrease. Now you can't decrease the dose in an auto-injector, but if you're injecting it, maybe you decrease the dose a little bit and pops, right? I mean, so you don't induce this heart attack. But so that's epinephrine, and it's very popular. Epinephrine is also used just in a different dose, in a different route. It's used IV. It's used IV in anaphylactic shock at a different dose. Anaphylactic shock, you would normally give 1 milligram IV, or in a CPR, it's the first line medication. Okay, so past defibrillation is epinephrine. They will repeat epinephrine over and over. What epinephrine does, part of its action, is it increases automaticity. So you have this in a cardiac arrest. You have this cardiac cell, and it's doing nothing. Okay? The heart is stopped, so that cardiac cell is doing nothing. What epinephrine, in its slang, I don't know if they still use this term or not, but they used to call it a chemical defibrillator. Okay? And so epinephrine you will pump epinephrine in with your good chest compressions, okay? And once it gets into the heart and system, they want it to, that cell, that cardiac cell, those cardiac cells, it wants to increase the excitability of that cell, okay? And then automaticity will hopefully kick in, and those cells will start to contract, and then we have what? Once those cells start to contract, we have what? We have contraction. We have contractility of the heart. And hopefully that contractility of the heart is strong enough to produce a pulse. Okay? Pretty much, I've always wanted to try this. I just never really got that far. Is get a fresh slab of steak. I mean, right off the cow. Right? And inject it with a bunch of epi. And I think that you would see contraction. Okay? You could take the heart, let's say that, the cow, so much for Chick-fil-A, right? Rip that heart out of that cow, and you're sitting there and it just, boom, you pull out and it boom, boom, and it just stops, right? Throw it down on the thing, hook the electrodes up to it, and just start injecting it with epinephrine. It may contract, right? I mean, right? If you put enough epi in a cardiac cell, it's going to contract. Okay? In the CPR, that's why they tell them that pulse is produced by epi. You may have heard that. That's an epi pulse. That's the drug keeping the heart going until that epinephrine burns out, or that half-life of that epinephrine goes away, then the pulse will go away. Okay? But anyway, so epinephrine is used in cardiac arrest as well. So it's a very multiple drug, very old drug, but it's one of the best drugs around. They tried to replace it a long time ago with vasopressin, and it's just another drug like Epi, and everybody think, ooh, this is it. This is going to change the world. It was really expensive, and we're back to giving Epi again because it didn't. Somebody bought off on all the fake research, and it just didn't work the way that it was advertised to work. So everybody went back to Epi. You know, instead of charging that patient a gazillion dollars, charge them, you know, a buck. Did you have a question?
Yeah. So for the Benadryl, like if we're giving it like through IV, like how much would we give?
Oh, good question. 50 milligrams. 50 milligrams. 20. Let's just give you the range. 25 to 50 milligrams is the dose of Benadryl. Some people give 25 IV, which is going to have a very quick onset, and then they give the other 25 IM for a lasting effect. Okay.
And like the pill, do you know how much it usually comes in?
The normal dose is each pill is 25 milligrams, I believe. And most everybody takes 2. If I took 2 Benadryls, you could wake me up tomorrow. Come by on your way to class. Hey man, get up. Because I'll be out. Okay, and then have a little Benadryl hangover at that, get that little fog going. It's bad, okay? Anyway, immunology, it's an immune response, okay? So the way that this takes place is the body has proteins, and it's called antibodies, which attack and destroy invaders' antigens. That's sort of what we talked about. So your antibodies is going to go up there and you have a foreign invader. And it doesn't matter what the foreign invader is. That medicine that they inject in you is a foreign invader, and the antibodies will go up there and sort of take a look at it, right? Picture all these little soldiers, and something comes in your body that's not supposed to be there. These antibodies will go up there and they'll look at it and go, okay, that's cool. Another antibody. You know, well, that's supposed to be there. Anything like this is a sort of a foreign invader. But here we have the little B toxin, which would be the antibody in there, or the antigen, and the antibodies are going to go up there and destroy that. And that's the normal reaction. If this takes place, this person is not going to have an allergic reaction because they had enough antibodies to destroy the antigen, okay? One thing that you have to do is you have to have this antigen introduced, okay? Penicillin used to be a big one. Peanuts triggers this immune response or this hypersensitivity or this allergic reaction. They call it all these different things. Most people just call it they're having an allergic reaction, okay? It is not handed down through generations, so if your mom or dad is allergic to bee stings, that doesn't mean that you are. Okay, you have to be exposed. There has to be an exposure first to have the allergic reaction, right? So your first bee sting, you necessarily won't get an allergic reaction. It's your second one after you've been sort of sensitized to that, okay? And then you have some that is harmless, like this allergic reaction here would be, and if it's only here, I guess this is on the back, maybe. Yeah, these look like big mosquito bites. But if you have mosquito bites this big, then you've had a reaction to that, you know. But anyway, if this is just on the back or located right here, it would be considered a localized reaction. It's just local, means that it didn't go anywhere. It's staying in one spot. Okay, so it's localized reaction. This person here, if they're not having any trouble breathing is one of the key signs. Would be a sign that hey, something else is wrong here. Something more is wrong. But if this stayed here, it didn't move. There was no streaking in the vessels. It was just this reaction here. Then this would be a localized reaction. So they could take some PO Benadryl if they wanted to sleep, If they didn't want to sleep through it, then Benadryl cream, get some Benadryl cream, rub on it, and then they may have to repeat that, a little bit later. It sort of take the itch away. Anti-itching cream is, the active ingredient is Benadryl, diphenhydramine. So it's they're going to take it away. The swelling, however, Benadryl won't combat the swelling. So if it's still sort of swollen up, you might have to get some hydrocortisone cream, steroid cream, right? You can buy it over the counter and rub that on there, and that will take care of the swelling. But this sort of redness and puffiness here, usually you buy a 75-cent tube of Benadryl cream, rub it on there, and it's gone. Localized reaction, no trouble breathing, right? Just itching right here, and some swelling, doesn't really move anywhere, no problem, no emergency. Right? Nobody's going to die from a localized reaction. Right? It's just very simple. You will be surprised on how many people come to the emergency department with localized reactions. And they check in, they want some treatment, right? When they should say, well, go to the CVS or something. I mean, it's a localized reaction. It's nothing. You're not having any other associated signs or symptoms, no problem. Right? It just looks bad sometimes. Okay? We switched soaps one time on my favorite UT blanket, and I was watching the game. It was all covered up. I was nice and warm because it was flannel. It was warm. And I said, man, I just hot. And why am I itching? Lift up my shirt, look down. I'm like, oh, the whole abdomen and chest was just all red, right? It was like going, wow, that's big. And so I went in there and took a little Benadryl, and boom, woke up, missed the game, but hey, redness gone, problem resolved. It was too big, so I didn't rub my whole body down with Benadryl cream. Anyway, so soaps, anything, any sort of change that you have, okay? So, so after this antigen is introduced into the body, okay, the antibodies remember that. So let's say a little bee sting. Little Johnny got stung by a bee. He's crying, big red spot on his arm, which is normal, but it's staying there. He's got a mild reaction to it, but it's just a bee sting. All right. Again, rub a little Benadryl cream on it, and maybe some ice, right, for that little bee sting. So, but the antibodies, like we talked about, these warriors are going to remember that antigen, okay, for next time. Okay, for the second time they were exposed. And then, of course, the medical term for hives is this weird word, urticaria. Nobody says that, by the way. Everybody just says hives. All right, but that's the medical term for, that's the medical term for hives. And then we talked about histamines, right? So release the biomass cells, these basophils, capillary dilation, sort of the permeability that start leaking, right? Bronchoconstriction, a lot of mucus production is all cause of histamine release. The histamine causes all the problems, right? So before my cat met his untimely death, I got built up an allergy to it. When I first got Kitty, he was cool. He was a cool cat. Man, we'd sit, we'd watch TV together. I pet him. He'd purr. He'd go out and kill mice in the field and bring them back to the porch and dump them on the porch for us to show that he's worth his weight, you know. And he wouldn't necessarily poo in his younger days in the box. He was sort of a wildcat. He'd scratch the door, and we'd go over and let him out, and he would never come back. He'd cat all night, you know. He'd come back with big tears in his ears and stuff. But anyway, I don't know what kind of catnip he got into, but he's a cool cat. Up to I developed an allergy. Developed an allergy to kitty. And so it went from sitting to my side, petting, watching football together, to get away cat. Just think, if the cat had if animals had sort of, conscious thought, right? They'd be like, can you imagine, what did I do? What happened? I went from being on the chair down to the floor, and now not even being in contact with you, right? So animals don't think that way. They think, why aren't you feeding me? Why aren't you petting me? You know, but so develop this reaction, but and so when I did get around the cat, my eyes would water, start sneezing, nose would run, eyes would itch, right? So you had this reaction to cat hair. So anyway, so all this would take place without the bronchoconstriction. That's good. I never got that bad. And so I'd have to go douse my eyes with liquid Benadryl and take some more allergy medication, but no more. So here's the things that take place in an allergic reaction outside of a localized reaction. This doesn't take place in a localized reaction, but what happens is you have bronchoconstriction, you have a shift in fluid, okay, and then vasodilation is sort of a last. That's when it gets really serious, when the vessel starts to dilate, as in anaphylactic shock, okay? And so through the bronchoconstriction, the patient feels like they can't get, they have dyspnea, like they can't get air in, right? And so air hunger. So they get where they can't get air in because those bronchioles are constricted. They get the swelling, the throat feels like their throat is swelling, and the tongue could start to swell. They just start having difficulty breathing. This is when it requires more treatment than just the Benadryl, okay? And then the most serious is when the pressure starts to drop. That is a very late sign, when the pressure starts to drop, okay? And that would be anaphylactic shock. Okay. And then you get edema. So you would get some pulmonary edema, this fluid. That would be a very late sign. So constricted vessels, pulmonary edema, vasodilation, all very critical signs. They need immediate treatment. Okay. This is where you would administer the epinephrine in there. So the first exposure, when we see the first exposure, they're sort of primed for it. It could just, this is a big allergic reaction, but this could still be just localized. Okay? No trouble breathing, nothing, just itching, big red splotches everywhere, no problem. Localized reaction. Take some Benadryl of some form. Okay? So it would be considered a mild allergic reaction. A moderate allergic reaction would be when the patient starts complaining of shortness of breath. So they got stung by the bee, and if let's say they're allergic to these bees, okay, and they get stung by the bee, it's going to be fairly quick. It's not going to be, a couple hours later I'm having trouble breathing. They're going to get stung, and the respiratory problems within a couple minutes. Okay, they're going to start having respiratory problems. So that would be a moderate reaction. put out to the side here. Once you have this moderate reaction, the patient gets short of breath, or they get bronchoconstriction. How can we tell that they have bronchoconstriction? Who said it? Wheezing, right? They wheeze. They start to wheeze. So all of a sudden they get stung by the little bee, and they get red, and they get all blotchy and everything. They start having shortness of breath within a minute or so, and you take your stethoscope out and say, yes, you have these wheezes, you have this bronchoconstriction. I'm going to go ahead and administer you some epinephrine. Okay, you have an Epipen. So you go through the steps of administering that medication. Do you have allergic reactions to it? Do you take epinephrine? Do you have an Epipen? Right? You start focusing your questions very quickly on their shortness of breath and to give them the epinephrine. And then the most severe form is when they have a drop in blood pressure. Okay? I've seen this within 5 minutes before. Okay? Where a co-worker of mine had an allergic reaction to gluten. I'll tell you a long story later. It's actually pretty funny. I enticed him in to eat a Danish, and we were at 1,500 feet in the air, and he started having an allergic reaction, and before we could land, less than 5 minutes later, he was in anaphylactic shock. We ended up having to intubate him, and he spent a couple of days in ICU. I don't feel bad about it. I tell you, that's pretty funny later. But anyway, so anaphylaxis, 5 minutes this could happen. Okay, so you don't have a lot of time. So why do these guys carry this Epipen? They don't have enough time. Let's say we had an allergic reaction here, a severe allergic reaction. How long is it going to take to get EMS here? They're right there. They're down the street. You don't know where they are. They're by Kroger, right? How many? Yeah, about 5 minutes, right? Legal by standard of care, they have 1 minute to accept the call, 1 minute, 1 additional minute to respond to the call, meaning that they get in their ambulance and then they come here. Most everybody knows where the school is, right? But if you're in your house, what do they have to do? Yeah, they have to look up the address, okay, or look at the map, GPS now. The GPS, back in the old days, which is not really that long ago, they had to look in a map to see where the house was. Now it comes up on a computer on the GPS, okay? So they have to look at that and then, okay, let's go. We know where it's at. Not everybody knows where all the addresses are, right? So it does take some time. That's why Epipen is so important. If you had an Epipen down in the nurse's office, it would take a little time, right, to get it here. So time is of the essence in an allergic reaction. Start looking. This is just the drug, the information we already talked about. 2 or 3 minutes to administer an allergic reaction. These severe allergic reactions, they go quick. Okay. So I was going to show, this is pretty cool, but I'm on the backup and it won't work on the backup thing. So anyway, let's take a minute and look at this Epinephrine Auto-Injector. Okay, comes in a container like this. Oh, I need a volunteer. Come on. What you would do, the needle in this, you have to think that, do I need to drop my pants or what? Because it goes in the thigh. All right, but the needle is about this long in there. And you don't have to have exposed the skin or anything. It's designed to go through a pair of jeans. In fact, I had one that's similar in that hard plastic sharps container up there. I injected it in the top, and it went through the hard plastic top of that. Okay, so you go through the steps like this. This is your auto-injector, right? And I don't have to really ask you a lot about it. It's yours. I'm just going to help you take it, okay? I'm going to assist you in it. So, but I would still do my part. You know, is this yours? Confirm that it's yours. Do you have any reactions to it? You have any allergies to medication? I mean, very quickly, right? Is she sitting there going, no, no, give me the medicine? Or she would snatch it from me and do it herself, right? So, but she's in a panic, so I'm going to help her out here. How old are you?
17.
Okay, so you can consent to that needle through the shot? Okay, no problem. One thing that we do is your look, make sure that it's in date. They all have expiration dates. Remove the cap, okay? Make sure that you have it upright, okay? Because if you have it the other way around, you will inject that into your thumb. It has happened to a trained responder before. She'd been stung by a bee, and she got in a panic, and she flipped the Epinephrine Auto-Injector upside down, and she went like that, and the needle went in her thumb. Okay? Huh? So you?
No, it was 4 to 5.
They have the safety cap. Okay? You remove the safety cap. The needle's on the orange end.
Oh.
Okay? So.
Orange.
So you find a thigh. You ready for this?
Mm-hmm.
It's no sting, but you're healthy, right? You don't have any health problems?
Yeah.
Oh, okay. So you find a good thigh. Don't flinch, because it'll hurt bad if you flinch.
Yeah.
You want to stick up?
Yeah, is that okay? She volunteered.
You're not going to stick her on Epipen. That's grow up.
Why not?
It's a practice. Are you serious?
Yeah. Why not? Take one for the team.
Just so we can see.
Yeah. So you go, ready?
Yeah.
You inject, hold 10 seconds.
10 seconds.
Man, that was tough. 10 seconds, and then release. And then comes out here. The needle will retract automatically inside, okay? And you're right, it's a trainer. So, but it was sort of funny, near to be a disaster. I have one. I put it on my desk, and it was in that basket a second ago. I was about to do the same thing. I was about to do it. I was doing the same, and I looked at it in the same. Let me just get it for you. Let me show it to you. Come on back up. Come on back up.
Another volunteer.
Go, Nicole.
No, that looks real. Wait. I don't. Oh, that one's white.
One of them
There's
got
green on the bottom.
What's the difference?
There's green on the bottom of one.
Yeah.
Oh, yeah, that one.
on your right hand looks real.
Anyway,
It will say trainers on one.
Go through
yeah, I was doing this, and I was doing the same thing. I removed the cap.
Oh no.
Yeah,
It went.
it actually came out.
Oh, my.
I think I went to a little
That's the real one. Put the cap on the back.
At least you get something.
You know, and then I picked up the one that says training device. So when you guys are practicing this, the first thing you look for is training device on the auto-injector. Right? Which one's with it? So,
You should do that to the fifth graders.
yeah, here, come here, little John. Alright, so let's look at this in review right quick.
That'd be so funny.
So local reaction, that's the one that doesn't move. It could be localized, but all of a sudden you start seeing streaks that run down in the same directions as your vessels. That means that it has got into the bloodstream and you need to seek medical attention, okay? But if it's just all splotchy and everything like this and it doesn't really go anywhere, that's still a localized reaction, okay? But it's the second or third time that you've been exposed, so you're primed for this allergic reaction if you're going to have one. You could be stung by multiple bees throughout your life and develop an allergic reaction to it. So you can develop allergic reactions to things. Food, all right? People say, oh yeah, man, I like to eat watermelon, but it makes the roof of my mouth itch.
Oh, that's good.
So you think you should stop eating that?
Really? I thought it was just like, because it was like,
But you still eat
like
them.
really
Yes.
sour.
Pineapple juicy, I thought that was no, it's
That
not.
itching in the top of your mouth is a mild allergic reaction.
So anything that feels funny is an allergic reaction?
Huh?
So anything that feels like...
No, sort of an itch, like an itch. Okay? So, you have this localized reaction, no big deal. When treatment starts to need to take place, it's this moderate reaction, the short of breath. They start having trouble breathing. They're saying that my throat feels like it's swelling shut. My tongue is, they're like, I can't talk a bit. There's swelling up here, okay? You listen with your stethoscope. There's wheezes. It's time to move towards the epinephrine. If they fall off into anaphylactic shock, they need IV therapy, vasopressors, because anaphylactic shock. All right. It's been a while, so I'll review just a hair because it's okay. A normal vessel, like here, normal vessel, in anaphylactic shock, the histamines and the things that associated with the histamines, okay, there's a bunch of other things that take place with the anaphylactic shock, but to keep it simple, in anaphylactic shock, it causes vasodilation. So you have this normal blood flow through here like so, okay, and now you still have the same amount of blood. The patient hasn't dripped a drop of blood out, but the histamines causes vasodilation, okay? And now, because of the container being larger, the pressure will drop severely. It will cause massive vasodilation, okay, which in anaphylactic shock. So here, we could give them, in the advanced life support, maybe what you'll see at the hospital, they'll start pushing fluids through them, okay? And then fill the container back up, which will raise the blood pressure, but that's only for a short time until they can get the allergic reaction under control. In a serious case, like my partner, they will put them on vasopressors, meaning that they will put them on like dopamine or something to vasopress or constrict the vessel. Dopamine is a vasoconstrictor. So it will take this big vessel here and chemically constrict it down to this, which will increase blood pressure drastically. You have to watch out when you give a vasopressor, or you see them giving a vasopressor, because when you give, it takes. Okay? So it's constricting that vessel down, but it's pulling, it's stopping blood flow to vital organs, like the kidneys. So it's nothing's free, okay? Neither's giving a vasopressor. It's gonna take something when it gives something. So it's gonna take renal function, it's gonna shut down the gut, it's gonna do quite a few things, okay? But we just remember, so you remember the term dopamine, dopamine. So is one of them. There's several. There's probably one that's more popular now. It's Levophed. I think it's Levophed. That's not how you spell it, but Levophed, we have this term, Levophed, leaving dead. It's a very, very potent vasoconstrictor, okay? And you will probably see Levophed before you see dopamine, but Levophed is an alpha drug. It's all alpha. So it's going to cause vasoconstriction, right? So you'll see Levophed, maybe dopamine, and these anaphylactic shock. Alrighty? Otherwise, if they don't go into shock, if we catch it soon enough, the epinephrine is going to bronchodilate. It's going to sort of relieve the swelling. We give the Benadryl. It's going to block the histamine release, block that release of histamine so the body can catch up to it. And then we still have one other problem that we haven't addressed. What is that? That none of these medications will work with. Swelling, right. Still swelling? Where's swelling? Southwest, yeah.
That's what I was thinking of.
Airplane. Swelling. So what do we need here for the swelling? The same in... Huh? Yeah, steroid. We need to give a steroid. You were right. Same corticoid steroid. Okay. We need to give a steroid for the swelling. So that would be the in-hospital treatment or out-of-hospital treatment. You'd still give the... So we'd give the Benadryl, IV, IM, epinephrine. The Epinephrine Auto-Injector is given sub-Q, subcutaneous. So under the fat, we'll learn how to give those shots later. And then if it's severe, we'll go ahead, even with the shortness of breath, we'll go ahead and give the steroid because the swelling that's there, okay? If it gets into anaphylactic shock, we'll pump them full of fluid, okay? And then if that doesn't work, then we'll give them a vasoconstrictor, probably Levophed, okay? So constrict them down until we can get the allergic reaction in check. Does that make sense to everybody? It's fairly straightforward on it.